Thank you, everybody, for joining us today for the first in our conference series on complex upper limb surgery. It's really a pleasure to be here. So my name is Kieran Agarwal-Harding. I'm the director of the Harvard Global Orthopedics Collaborative and Sona Global. It's really our pleasure to put on this session. Today's session will be on brachial plexus birth palsy. Next slide, please, Samita. Big thank you to our partners in this: OTA, Ganga Hospital, the Indian Society for Surgery of the Hand, and Alert Hospital in Ethiopia. So our course involves 4 live sessions. Today's first live session is on brachial plexus birth palsy. Next week on Saturday, we'll do upper limb tendon transfers. And then in early December, we'll take a little bit of a break and then start again on December 6th with distal radius fractures, followed by upper limb soft tissue coverage. So just as a reminder for all of us, with Zoom, please do mute your microphone if you're in the meeting and not speaking. But of course, if you have a question, please raise your hand and we'll be happy to include you in the discussion. We do have the ability on this Zoom to have closed captioning in your language if English is not your first language. So just follow these instructions. There should be a little icon to show captions, and you should be able to select the language that is most comfortable for you. We also have the ability to type questions in the chat, and I'll be monitoring that as we go through. So please feel free to type in messages into the chat, and we'll include them in the conversation. As many of you probably already know, we have this flipped classroom model for our courses where faculty, including Dawn and Andy, have recorded phenomenal lectures as part of a pre-course curriculum. This can all be accessed for free for all of our community online. Just go to sonaglobalacademy.org and you just click on the login at the top of the screen. And then in this next slide, you just click on create a new account, and that will prompt you to create a new account. And that will give you free access to all of our educational material, including the recording for this session. These are the slides that you will see if you log on to Sona Global Academy. You'll have the ability to view all of our full curriculum. Thanks, Amrita. So before we get started, I just want to reiterate the course objectives that are really universal to all of the courses that we run at HGOC and Sona. First and foremost, it's to improve participants' knowledge. Second, it's to foster international discussion and provide and then third, motivate and support the younger generation of surgeons globally. So as I mentioned earlier, my name is Kieran Agarwal-Harding. I'm the course chair, and it's my pleasure to introduce Andy Bauer, who's our session moderator. Next slide, please, Samita. I really want to thank our incredible HGOC and Sona organizing team. Every individual you see here has put in hours and hours of work to organize the session, and we could not have this as a possibility without them. So thank you so much to the HGOC and Sona team. And it's really my pleasure next to introduce the case presenters for today. So first is Dr. Ndefatu Coulibaly, who's coming to us from Senegal. She'll be our first case presenter. Second, we'll have a case from Dr. Praveen Bhardwaj from Ganga Hospital, also one of our co-organizers for this event. So thank you so much, Dr. Praveen, for being part of this. And then Dr. Shoaib Javed, who will be presenting from Pakistan. So thank you so much, Shoaib. Next slide, please. And along with our case presenters, we have fantastic case discussants. Our 3 case discussants, including our course moderator, Andy Bauer, are all pediatric orthopedic upper extremity specialists from Boston Children's Hospital and Harvard Medical School. So we've got Dr. Donald Bay and Dr. Benjamin Gundlach. So thank you so much, Don and Ben, for joining us. All right, well, so this is the agenda for today, this quick introduction, and we'll jump right into our first presentation from Dr. Ndefatu Coulibaly. Thank you so much, and welcome all.
Hello?
Yes, hello, doctor.
Ende Fatu, can you hear us? We can't hear you yet. If Ende Fatu is having trouble with her slides, we can then move to our second presenter, perhaps. Ende Fatu, are you still struggling with your slides? We can't hear you. All right, let's move to Dr. Praveen's presentation first then, if that's okay. Praveen, are you ready to go? Can you unmute for me, please, Praveen?
Is my slide visible?
Yes, very visible. Thank you, Praveen.
Okay, hello everyone. I have selected to present a case of supination deformity of the forearm in birth palsy because this is one topic which is not so much discussed in many of the conferences or in the literature. And however, it is quite challenging and there are many considerations and important things before we consider these patients for surgical correction. This is not a very unique or challenging case presentation. In this case presentation, I would be basically telling about various important factors which you think of when you do the correction for this deformity and what could be the patient expectations and what outcome can be expected for such patients. Presenting this girl who is 10 years at presentation with the deformity of the forearm. She has had a birth brachial plexus palsy and not undergone any kind of surgical intervention till the presentation here because she was seeing that there are some spontaneous recovery happening and she was told to wait. Now, parents' main concern is that the hand looks very odd and they want some kind of cosmetic correction, and of course, whatever best functional correction is possible, they are very keen on getting it done. So when we see a patient like this, there are the few important treatment and assessment considerations which we should think of. When a patient has a supination deformity, first of all, it gives a very poor appearance to the hand, which has been termed as a beggar's hand or an unshakable hand in some articles. It is also functionally a very bad position because a person would have great difficulty in picking up objects from the tabletop. So all the tabletop activities require pronation and which these patients are not able to do, and hence they will be quite disabled. Though normally people can compensate at the shoulder for lack of pronation, but these children who have also shoulder involvement are not able to compensate. Often because the wrist is hyperextended, the hand does not reach to mouth, and they even have a difficulty in just turning a page of a book. Hence it appears, though it may appear as if like it is not a very common problem, but when the patients have this, it is a great disability, both cosmetic wise and functional wise. When we are treating these patients, there are many important things which may be associated and will require consideration. First of all, whether there is any deformity at the shoulder, which can conceal the supination deformity, elbow flexion deformity. All of them would have a pattern where the wrist flexors are weak, but the wrist extensors may be quite functional. Similarly, finger extensors would be weak, but finger flexors would be good. Because of the supinated posture itself, the thumb goes in adduction. And because of this abnormal posture, the hand would be used much less than what would be dictated by the power in the fingers. And that is the reason why it causes a lot of disability. When you think of correcting this deformity, there are many operations which have been described. we generally follow this kind of protocol. If the deformity is fixed and it is not almost completely passively correctable, we straight away go for a pronation osteotomy. If it is passively correctable, then the option is to do a biceps rerouting or brachioradialis or ECU transfer. If the triceps is functional, we do biceps rerouting. However, if triceps is weak, we do a brachioradialis rerouting or ECU to ECRL transfer. This is the general plan what we follow. So this particular patient had a fixed deformity. When you have a fixed deformity, another good way to grade the deformity is by checking the position of the thenar eminence. When the patient is standing straight, if the cubital fossa is not seen, that means there is a deformity in the shoulder. And we start assessing the forearm deformity only when the shoulder has been corrected. So this child, we can see the shoulder is facing front, the cubital fossa is facing front. So there is no deformity in the shoulder, but there is a supination deformity. If the thenar eminence is seen anteriorly, that means it is a mild deformity. Normally, when a person stands, it is the dorsum of the thumb which will be facing front like this. This is a mild deformity which often can be corrected by tendon transfer. A moderate deformity where the palm is facing front. Such patients would have often a fixed deformity and would require pronation osteotomy, but often only radius osteotomy is sufficient. A severe deformity where hypothenar eminence is facing front. Such patients would require either a one bone forearm creation or osteotomy of both radius and ulna. So that's why this categorization is quite useful. Now coming to our patient who had a fixed deformity which was not passively correctable. She had wrist extension possible, which is again a very important prerequisite for correcting the supination deformity. Because when you are correcting a deformity, you are creating a pronation posture. And if the wrist extensors are not working, the patient will develop a wrist drop, which is more disabling than having a supination deformity. And the correction required was at almost about 120 degrees. This patient, we did a pronation osteotomy. We can see fixed with a 4-pole plate. Two important things over here, how much to rotate. The aim is to bring the forearm in 30 degrees pronation. Why 30 degrees pronation? Because that is the natural standing position. And also when the hand is placed in pronated position, we remember I told that these patients have deficit of wrist flexion. So when the forearm is put in pronated position, with gravity itself, they are able to do a wrist flexion. And this wrist flexion also allows them to open up the fingers a bit. So that is the reason why we need to put it in 30 to 40 degrees pronation and not mid-prone. We can generally rotate about 120 degrees by doing radius osteotomy alone. You can just add some interosseous membrane release to that. However, if more rotation is required, or ulna osteotomy also would be required in those cases. This is the same patient after the surgery. This is at about 2 years follow-up. You can see immediately the standing posture becomes nice and the thumb is facing front. So that is the natural standing position when a person is standing in with both hands looking quite symmetrical. And immediately you get a good look to the hand. So which patients really love, and also these children feel more comfortable when going to the school and going to the public. It also improves the function. The topmost, most important is all the tabletop activities would improve. Many of them could hold a glass and reach to the mouth more effectively because now they are not having the wrist going into hyperextension posture. But out of all the things what improve, I think personally patients most satisfied about the improvement in the appearance. So it is no more a kind of beggar's hand type of position. However, especially in Indian situations, one need to be very careful when doing this operation because in India, there is a culture of eating with right hand. So once you have decided that you are going to do a pronation osteotomy, we must know that the child will not be able to do supination and eat with the hand with that hand. So that's why we reserve this operation only for patients where hand is not good enough for eating or child is not eating that hand for eating food. So to summarize, forearm deformities are quite common, especially in patients who have more extensive involvement of brachial plexus, supination being the most common deformity, which requires a surgical correction. By just placing the hand in more functional position, you improve the appearance of the upper limb and you place it in a more functional position. And just by placing it in better position, you dramatically increase the functional capability of the hand, and it is associated with good patient satisfaction. Could even say that the unshakable hand gets converted to a shakeable hand, and a beggar's hand could become a happy hand. Thank you.
Praveen, that was awesome. Thank you so much. I think some people were saying your volume was a little bit low. Maybe just speak up as we have people ask questions. Please put things into the chat if there's any questions from the participants. And maybe I'll start with a question for Praveen, and then we can also loop in Don and Ben. So first question is that you mentioned lack of wrist extension as a contraindication because then once you're into pronation, you'll have a wrist drop.
True.
Would you ever consider a two-stage operation or doing an osteotomy and a wrist extension transfer at the same time? And how do you think about that kind of decision making, or is it a hard no? Just either one operation or none?
Yeah. So yeah, that's a great question. I think since these children do not have a very good donors, so many times the tendon transfer may fail. So I think it is safe to first do a tendon transfer and make sure that you get a wrist extension and then do the pronation osteotomy. So because if the tendon transfer fails, we again get a wrist drop, which is not nice. And if there is no option at all, the tendon transfer fails, then I would keep this child for some time and consider wrist fusion at a later date.
That's a great point. So instead of going, I think a lot of times in these multi-level conditions, we think proximal to distal, but saying that we know the results of wrist extension transfers when you don't have great donors are inconsistent, that's a great idea. Like try that first and see if it works. See, I knew I was going to learn something. We're 10 minutes in. Dr. Bay, Don, any thoughts on timing of this surgery? You know, I think we have the privilege of having kids present earlier in the US than they do in a lot of other countries. So if you get to choose, you know, any thoughts on timing of when you might do an osteotomy like this?
Yeah, great question. And Praveen, thank you. That was a beautiful case and a beautiful presentation. You know, I learned not only to remember about appearance and social function, I think it's really important to remember to assess the wrist extension and finger extension, and also understand that in the bad shoulder, it's hard to compensate for this, which I think leads to Dr. Bauer's question and Andy's question, and also a question that I have for you. You know, it's nice when you can avoid bony procedures and the supination deformity is still flexible. I think in different centers, people will see it when it's still flexible, and sometimes they'll see it when it's fixed. I'm very surprised, though, how tight the soft tissues can be. So my questions for you are, do you think the recurrence rate is high after a soft tissue procedure only? In other words, should we be doing both bony and soft tissue procedures together? And can you share with us your tricks or technical pearls on how to get so much rotation with only the radius osteotomy? Because 120 degrees in just the radius for me that's considerable amount.
So yeah, to the first question, I agree that there is a more recurrence rate with the soft tissue procedures, especially if you have not done the biceps rerouting. because biceps rerouting is a good operation. It will not have a recurrence because you have removed the deforming force itself. But brachioradialis rerouting will have a high recurrence rate. And I think it should be done only along with the bony procedure. Alone, it would not be sufficient. But biceps rerouting is good. I think whenever we have done in younger children with a fully passively correctable deformity, there is no recurrence. When we do a bony procedures, again, the literature says that the recurrence rate is quite high, reporting almost 35%. But I think the recurrence is high because these patients have undergone undercorrection. Because many patients, not only they have supination deformity, their forearms are hypersupinated. So if you calculate and do, suppose you tell I have done 120 degrees rotation and he had 45 degrees hypersupination, you are only doing an 80 correction. So it is in the first dressing itself, you would think that the correction is less, and then it is going to recur. If you have given considerations to that hypersupination, think the recurrence rate is much lesser. And if there is a ulnar deviation deformity, we would always transfer the ECU from the radial side to the ECRL. That acts like a dynamic corrective force. So by these two techniques, we are able to reduce the recurrence rate considerably. About turning to 120 degrees, sometimes we have done even 140, sorry. So I think the trick in this is that is to release the interosseous membrane and pronator quadratus liberally. Once we have done that, we are easily able to rotate by 120 degrees. But I am never like totally after that only radius osteotomy we are going to do. If we are not able to rotate easily to 120, then we will do an osteotomy of the ulna as well.
Yeah, so Praveen, it's a wonderful point. Would you agree it's fair for us mere mortals? It's not a failure and it's okay to do both bones. Would you agree with that statement?
Yes, very much.
So I think that's an important message for all of
Right.
us together
Yeah.
as a community.
Yeah.
Instead of pushing the radius, particularly if you're not as comfortable doing the interosseous membrane releases, it's okay to do both bones, and it's going to be perhaps an easier correction.
Totally okay to do, yeah.
Um,
But when we
One
are doing
good
both
question.
osteotomies, I think we need to be careful. We should not do an undercorrection. Because when both the bones are cut, you really don't know how much you are rotating. So we need to have the marking wires to make sure that you have done enough correction.
Whether you're cutting one bone or both, I think there was a good question in the chat about the compartment syndrome risk for these really extreme derotational osteotomies. Is how do you address that, in terms of your surgery and post-operative management?
Yeah. I think once the interosseous membrane is released, the risk of compartment syndrome is not there. In fact, whenever we are doing for a congenital radioulnar synostosis, we are very worried. But in birth palsy, we are never worried because the soft tissues after releasing the interosseous membrane are not that stiff. So once you release the interosseous membrane, it is not a concern.
Yeah, so really thorough release. Ben, I saw you answering some questions in the chat about donors for wrist extension transfer. So even though that's not exactly our topic, I think it goes together with this topic. So can you talk a little bit about options for donors for wrist extension and brachial plexus birth injury?
So I saw in the chat when somebody has written pronate teres. I think pronate teres is not available in patient with a supination deformity. So that is the main reason why the supination deformity is happening, because the pronators are not working. So pronate teres won't be available for restoring wrist extension. The options which we have is the ECU to ECRB transfer, or FCU is working, then you should transfer the FCU to ECRB. FCU to ECRB is the only reliable transfer in birth palsy, because I think FCU is the only muscle which we can very easily check whether it is working and it is powerful. So Andrea was asking whether you would do tendon transfer and osteotomy at same time. So in a patient where the FCU is working well, I think we can do both together because that is one reliable transfer. Other than that, nothing can be relied. We cannot trust the FDS, we cannot trust the pronatitis, we cannot trust the ECU. But if FCU is good, I think that is the best transfer for wrist extension.
And Ben, can you tell us a little bit about the FDS transfer for kids who have that?
Yes. Yeah. So I think obviously Praveen has a wealth of experience in taking care of these children. One of my mentors that I trained with was Scott Cozen, who prefers the FDS transfer for these patients. With some of the thought process being that typically with upper trunk and extended upper trunk injuries, these children are going to have lost their FCR function. And so if you're transferring FCU, then you may be taking a lot of their wrist flexion power. And that ability to dynamically change their wrist position and help with tenodesis can be important in this patient population. And so the FDS, typically, if their lower trunk is preserved well enough, their FDS may not be perfectly strong, but transferring two of those tendons around to the metacarpals and transferring around the metacarpals can produce some ability to actively extend the wrist, but also just reposition the wrist into some wrist extension as more of a static transfer. I know Dr. Cozen would talk about early in his career, he would put both of those through the subcutaneous tissue around the forearm, but then that had the recurrence or in children that were getting that as an isolated transfer, it would actually produce some of that supination moment itself. And so typically him and others would recommend transferring one FDS through the interosseous membrane and then the other FDS around the forearm and the subcutaneous plane. And then typically you can either weave those into the ECRB and ECRL or just transfer them around the base of the third metacarpal and then weave them back onto themselves. So, but yes, to Praveen's points, a lot of our typical donors that we're thinking of for wrist extension are not really suitable in the BPBI patient population, either due to weakness or typically due to weakness because of upper trunk injury. Yeah.
Praveen, we had a question about 3D planning for these osteotomies. Do you ever use 3D planning for your more complicated deformities?
No, I have not used. And actually, here, since it is not like a three-dimensional deformity, you are just going to rotate, though it can be done, but it is not much required, I think so.
And I think one important difference for these kids, right, is that once they've gotten to this point, the ones that you showed that are 120 degrees supinated, they don't have active motion. And so we're not trying to do a complex reconstruction to restore active rotation, which is a reason that I personally use a lot of 3D planning for. But in this case, you're just trying to change that static position. And so, I think some of these concerns about like the bones running into each other or, that we might not understand the deformity, I think it's less so because it doesn't have to move after.
Could I ask a more ignorant question here, Andy? As someone who doesn't do these kinds of surgeries, it's really amazing to hear you guys talk about this. Thank you, Praveen, for a great presentation. So Andy, to your point, when you rotate the bone over, I guess you don't care so much about congruence of the DRUJ or anything like that afterwards. Is that right?
Yeah.
Okay. Okay, great.
Yeah, and I think, Praveen, would you agree? And I think one, it doesn't have to rotate, and two, I don't think we see a lot of pain in the, if the DRUJ isn't congruent or something. Like you might think that would be painful, but I personally haven't seen that. I don't know, Praveen, if you have.
No, they actually that is the reason I think we can rotate to any amount because they are not having pain. And even if it is not rotating, sometimes you just clip the DRUJ capsule, you can further increase it. And you are never worried about the DRUJ incongruity at all.
Mhm. That was actually my next question, was whether you ever have to fuse the DRUJ because of pain or something like that. That's great. Thank you. The other question from the chat that I'd love to discuss is the timing of all of this. At what age is it appropriate to intervene on children? And how do you stage it? How long do you wait between doing, the biceps rerouting you were describing before you do the corrective osteotomy?
Yeah. These days, we try to do it as early as possible. If it is passively correctable, we would do a biceps rerouting maybe at about 4 years of age. But generally, patients present late. And if the deformity is fixed, then we don't hurry up. We try to postpone it till about 7, 8 years age, because the radius has to become big enough to put a plate. But there are some children who at 1 year itself or 1.5, 2 years itself have such a fixed supination deformity. In those patients, we just do a subperiosteal osteotomy and rotate the forearm in full pronation and put a cast for them. That also does well. So either I do it before 3 years or do it after 7 years.
And Praveen, so I think you said young patient, flexible deformity, biceps rerouting. Old enough to put a plate on, fixed deformity, we're just doing the osteotomy.
Yes.
In a younger patient with a fixed deformity, do you do both to avoid the risk of recurrence of the deformity? Or do you think it's better to just wait?
Yeah. In a younger patient, we will do a pronation osteotomy without a fixation. So just a subperiosteal osteotomy and rotate in pronation and keep. We don't do tendon transfer. We let the child grow and then think whether the tendon transfer would be required. Then we would take ECU, because now it has become a flexible deformity. And then we take the ECU, reroute it from the radial side and attach to the ECRL. So it acts like a nice stenodesis in pronation.
So not adding a biceps rerouting, but an ECU rerouting.
ECU rerouting. Because biceps, sometimes it is a bit fearful that you are removing the biceps, what is going to have to elbow flexion. But ECU is never a worry. But with the subperiosteal osteotomy, since it is not so stable, we are worried to add tendon transfer to that. So we want to get unite, and after that, if we feel like it is going for recurrence, then add on the ECU transfer to that.
That's
Andy,
great.
do you mind if I invite Federico to ask his question? Because I think he had some really interesting questions in the chat as well. Federico, are you able to, do you want to ask your questions live?
Oh, yes, if possible. I was wondering if in such a case, a single bone forearm would be a good option or not. And even usually we resect 1 centimeter. We shorten the radius 1 centimeter to avoid the risk of compartment syndrome, as we've been taught by Scott Cousin in Ethiopia. I don't know if would it work in such a case, and if there's not enough wrist extension and later on you have to perform a wrist fusion, would you consider resecting the first carpal row to avoid loss of finger flexion? Thank you. Sorry for the long question.
Yeah. Sorry, I didn't get that second part of it. If we are doing a wrist fusion, then
would you consider a resection of the first carpal row to avoid or to lessen the risk of losing a bit of finger flexion?
okay, yeah. So if the wrist is not passively correctable, then we would do the proximal row resection. If wrist is passively correctable and going straight, then proximal row carpectomy is not required, because these children already the hand is short. We don't want to shorten it further by a centimeter or two. Yeah.
And when do you make that decision to go to a single bone forearm instead of a rotational osteotomy?
Yeah, actually, every time I think if we are not able to correct, we will go for a forum, one more forum. But till now, I have not done even one.
See, the
So
rest
we
of us
keep
are
it
just not
with
releasing enough.
yeah. So till now, I had not done even one case of forum, and I think maybe we would have done more than 100 osteotomies till now. So,
That's great.
but we should keep that in mind, I am sure. Yeah.
I think, Andy, though, it speaks to a really common principle that we're going to hear throughout this session. I think there are many ways to change position, shoulder, forearm, what have you. Some is through the bone and some is soft tissue. And I think everyone on this in this community has their own comfort zone. For some, that's two bones with limited soft tissue release. For others, it may be one bone osteotomy with more extensive release. But I think awareness of both components of the problem is probably very important.
Karen, should we move on to our next case?
I think so. Fantastic teaching points from this, and thank you, Don, for summarizing it nicely at the end there. Yeah, please, Andy, go ahead.
Thank you, Andy. Thank you, Don.
Or I guess I should say,
That was excellent. Okay,
It
so
was.
Inde Fatu, do you think we can get those slides up this time? We'll see you.
I think Inde Fatu's camera is off, and I've texted her. So we'll see if we can get her up and running again. Samantha, if you don't mind chatting with Inde Fatu to help her out, that'd be great. But, oh, here we are.
Oh, perfect.
Inde Fatu, I don't think we can hear you yet.
Yes, you hear me?
Yes,
Okay.
we do. Thank you so much.
Okay. Thank you. Thank you very much. Thank you, distinguished members of this session. We are honored to present a case of obstetrical brachial plexus palsy that we manage in Senegal by nervous primary surgery. And I would like to thank the entire organizing committee for inviting us to this clinical case session. And please excuse my English, which is far from perfect. This is a little girl who was referred to our hand surgery department. She was 8 months old, and the paralysis had been diagnosed when she was 2 months old, and her mother reported a history of shoulder dystocia during delivery. And she also weighed more than 4 kilograms at birth. And on examination, it was a typically C5, C6 palsy, and at this age, shoulder abduction and external rotation were both at 0 degrees. At the elbow, active extension was present, while flexion was still absent. And the wrist and hand function were normal. Only an electroneuromyography was performed, and we did not consider it necessary to request an MRI. It is very expensive here. At 10 months of age, because of she had no elbow flexion, the lesions are very important, and we decided to do surgery from faster result to avoid long physiotherapy seance. And we performed it at the brachial plexus approach, like that. And intraoperatively, we found a neuroma for the upper trunk in this area, the upper trunk. And we do a resection for the neuroma. It is just pictures to explain it. We do the resection of the neuroma, and followed by a spinal accessory nervous transfer to suprascapular. Now here are is spinal accessory nerves here. Thank you. And biological glue is done, is the suture, but you can suture your, you can do microsurgical suture with refill. Donc first we do suprascapular, a transfer for spinal accessory nerves to the suprascapular. And first we do a graft connecting C5, C6 for the upper trunk using the sural nerves. And after we do this type of immobilization for 6 weeks, followed by physiotherapy. And we see her at 6 months. He begin to have motion at 1 year. And for this, she was seen at 18 months post-operatively. And we see that she had a full external rotation of the elbow. Abduction more than 120 degrees. And she do also flexion for the elbow. And she even helps her mother in the kitchen. And she is classified as mallet grade 4. Okay, so before finish my exposition, I would like to thank Doctors Valentin, Atlani, and Daf, who introduced us to nervous surgery on the brachial plexus in children, as well as traumatic brachial nervous surgery. Thank you for your attention.
Great presentation. We're already getting some questions in the chat, so please feel free to put those in. I think first point to touch on here is the tools that we might have in different settings in terms of deciding to operate. And so, you know, in Boston, we use a lot of MRI. It's way easier for me to get an MRI than an EMG. You know, you mentioned MRI being too expensive, and so using EMG. Other places, I think, routinely don't use any of that. And so I think I'd be interested, Inde Fatou, in your experience with EMG and when you choose to use EMG and what you're looking for. And then maybe we can have others weigh in too.
I can answer now.
Yes,
So,
please.
okay. We let me noise here. You know, it is AMG requested by the first physician that meet the children. So it is not an obligation to do AMG. I think that clinical exam is best to take the indication for operation or not, or to follow the children. But it is not an obligation, because result was too mitigé, too mélangé. Les résultats sont mitigés. Not clear. Sometimes it is not clear that it is very clinical examination is very better.
Yeah, so no obligation, you know, depending on what setting people are in, no obligation to get a pre-op EMG, no obligation to get an MRI. I think it's still kind of a worldwide consensus that clinical examination over time can tell us which babies would benefit from a nerve exploration and a grafting nerve transfers, like was shown so beautifully in this case. Praveen, what are you guys doing at Ganga? Are you using any preoperative testing? Oh, you're still muted.
Yeah, we do MRI. I think it is useful because it sometimes when you are having a doubt about labeling a root as good or not good, MRI can be helpful. But we don't do the nerve conduction studies. In children, I think it is not so much reliable and not so much necessary also. You get enough information by clinical examination and then top up by the MRI.
And then
we ask MRI in our position when we have full complete person to know when we can do the operation, because more fast we do the operation where we have some aversion of the trunk, better it is to have more recovery for these children, I think.
And then Federico asked a question in the chat about ultrasound, you know, and using ultrasound to look for neuromas or potentially even preganglionic injuries. And I don't know, that's actually a question I would throw out to everyone. That is not something we have been able to do in Boston. And I think, you know, like I said, we all have different resources in our different institutions. And I think sometimes when you have a really good resource, like our MRI is great, it hinders the development of other resources. So is there anybody in the room that has experience with ultrasound?
I see that someone asked if we use TCUL. TCUL is very, very, very expensive, very expensive. So when you have to do many shutter, you can use it to go fast for your intervention. If you have more children to operate, you have to take it. If you have, if you have money, so
if you have the means.
Means, okay. So I think that all hand surgeon can do microchirurgical suture with suture thread. Je cherchais le mot fil de suture. Donc, suture thread. When you can do your suture by suture stress, or even if you take a physical, it is very expensive. Even you are in African country, so they have not means in our country. So sometimes we can get it, and it be very useful for us to get it, to be very fast on this operation, because this operation take many time. 3 hours, 4, 5 hours if it is complete policy, and it is very good to have it. So it is not obligation.
I think that's a great point, that there's a number of there's not been shown a lot of difference in these techniques. So we talked about preoperative testing. You know, if you don't have access to any of these modalities, clinical examination over time as the baby gets older is a perfectly acceptable way to determine your surgical indication. Looking for return of biceps function, looking for return of shoulder elevation. If you don't see that by 6 months of age, you know, we know that the results of microsurgery are better than the natural history, and so you don't need any adjunctive tests. Same thing intraoperative. If all you have is suture and you don't have fancy glue, that's fine. There's not been shown a difference, you know, in terms of the outcomes of glue versus suture. And so whatever is safely available in your institution is fine. Ben, did you want to add something?
Yeah, I was just going to respond to Federico's question about other options to evaluate preganglionic versus postganglionic injuries. I know Dr. Linda Yang at the University of Michigan several years ago had published their use of ultrasound, and for upper trunk injuries, it had quite good sensitivity for evaluating for whether there was a neuroma or not. But they did start to have more difficulty with C7 and especially C8 and T1 injuries, and being able to evaluate that, just because it's deeper in the neck, and the ultrasound had less ability to resolve that. And so I guess if ultrasound specifically is what you're interested in, there has been some research looking to validate that, if that's something that's available to you in country. But then to the overall point of these adjunctive tests, ultrasound, EMG, and MRI, even in places in the world where they have every resource available to them, have still determined that these don't reliably give them additional hopeful information, and still just rely on serial examination and then intraoperative findings. And so I think that speaks to, if that's all you have, that's still the most powerful thing for evaluating these children, is just seeing them back frequently to follow their examination. And then if they haven't recovered, your own direct examination of their nerve roots, in most cases, is going to be the best evaluation over many of these other things.
Ben, sorry to clarify, you mean intraoperative evaluation of the nerve roots? Is that what you mean?
Correct. Well, if it gets to that point, right? If they haven't recovered and you're trying to assess whether they have an avulsion versus a rupture, I think many people would say that their direct kind of visualization of the injury in the nerve roots is still the most sensitive test, if you will, for determining these things. This is not just my opinion, but many others who do these operations frequently, like Dr. Pondag and Malaysi, I've heard speak about this, that throughout their careers have used EMG and intraoperative neurophysiologic testing and MRIs, and still have arrived at the opinion that their assessment with their two eyes in the operating room is the most sensitive assessment. So it just speaks to the fact that in these children, you don't necessarily need all of these technological tests and assessments to perform good, reliable surgery on them.
That's the point I think that I wanted to highlight here, especially for our audience, many of whom are surgeons working in resource-limited settings, who may not have access to MRI, and certainly not anything more than just suture to do nerve repairs. My question to everybody is, what advice can you give surgeons working in these resource-limited settings about how to pull the trigger and how to on doing surgery for these children, and how to plan that surgery appropriately? And also, is this surgery being performed with, and Defatu, my question is really for you. Are you doing this with loupes, with a microscope? How do we build the capacity to be able to perform these kinds of surgeries in resource-limited settings?
We do surgery with loop, uh, 4, 5, or 3, 5. You can see the growth and the fiber, the micro fiber. When they are avulsion, we see it is avulsion. And after we can, I see in this chat that somebody asked that what are your tips for delimiting neuromal rejection? Because when you do the rejection, you see when you have normal or not. So when you have a section of nerve, you can see that you have the fiber, very distinct fiber, and when fiber is ill, you can see it also. So, and after you can delimate it, you can delimate your rejection. Thank you. I'm very sorry. I'm English.
No,
I don't know if you understand what I'm saying.
Yes, and I think so you don't need a microscope to do this. You can see very well with 3-5, and especially if you have 4-5 loops. The other point I want to make is that the baby in this case was 10 months old at the time of surgery, which is much later than high resource countries are operating, but it has never been shown that the results are worse. We looked at this in a big multi-center study in the US that showed that the results of surgery before 6 months of age and after 6 months of age are the same. It's not the same as in adult brachial plexus injuries, they come off of motorbikes or whatever, and we have to operate very quickly. It's a very different phenomenon. And so I think if it's safer for you to wait, make sure that the baby really needs the surgery, and to operate in that 9 to 12 month range, these were excellent results. Those results are the same as what I get at 5 months, no worse, maybe better.
5 months.
So that was really great to see that you can have really great results in a 10-month-old baby doing grafting.
Yeah.
So that was wonderful.
Andy, there's a really great question here from Ibrahim Luciola about pre-surgery physical therapy.
Yes,
please go ahead.
I think physical therapy is essential from the time that the injury doesn't hurt anymore. So probably 2 or 3 weeks of age, to start passive motion and moving the arm in the ways that the baby cannot on their own move the arm. So anyone with a persistent brachial plexus injury beyond a couple weeks of age should be getting physical therapy. And whether that's, it doesn't have to be in a center, those can be exercises that the family is doing at home. But stretching exercises to maintain the flexibility of the joints, I think, is absolutely essential prior to surgery.
Could I invite Praveen maybe to make one last final comment on this case and the way that they manage this in India before we move to Dr. Shoaib's case?
Yeah, I think as Andrea mentioned that 6 months, or I think much before it was 3 months. So anybody who has not recovered at 3 months, we must operate. That is slowly fading, and I think it's not true. We can go till 6 months. And if it is an upper plexus palsy, even 9 months, 10 months also is okay. Especially, we should keep in mind that we should not think like the child has become 10 months and we must not operate. In many resource limited settings, even in India, a lot of children come when they are 10 months. We should not deprive them from the benefit of surgery, thinking that child has become 10 months. For upper plexus, even 1 year is okay. And even an extensive palsy, you are operating at 9 months, you can expect to have much better result than not operating. So
Thanks,
I
Praveen.
think that would be a good point for everyone to remember.
Fantastic point. Thank you. Shoaib, would you like to present next? Is that okay, Andy, if we move on to the next case?
Yeah, great conversation, but yeah, let's move on.
Fantastic. And Defatu, thank you so much for a fantastic case. Really remarkable what you've been able to achieve in Senegal.
Thank you.
Very
Thank you.
inspiring. Thank you. Shoaib, we can't hear you yet. Can you unmute?
Okay. Can you see my screen?
Yep, and we can hear you.
Thank you. So I'm Dr. Shoaib. Sorry for my voice. I'm supposed to work as an upper limb surgeon, but sometimes I also have to do knee surgery. So in the resource limited or in the developing countries, the patients usually present late, 2 years, 3 years of age. The usual presentation in my practice is after 2 to 3 years. So for them, the internal rotation contracture is a big problem. So I'll present my case. She's a 7-year-old female, had right-sided obstetrical palsy. She had a trumpet sign. She's unable to bring her hand to the mouth, and she has no external rotation. So if I can show you her preoperative videos. You see, she's trumpeting and she's unable to bring her hand to the mouth. And the external rotation lag sign is positive. Now, this particular case, she was operated by another surgeon. Her arthroscopic release of subscapularis was done, which got infected. It took her 6 months to recover. And so this is the reason she has good passive external rotation. So internal rotation contracture is very common contracture in obstetrical palsy. It develops even if the full neurological recovery occurs. The deficient shoulder is an exhausting issue in brachial plexus palsy. And classically, latissimus dorsi transfer has been the mainstay. It is a very good transfer. I also do it, but it has certain downsides. LD is an intraplexal muscle, so it undergoes denervation and renervation. LD is not in line with infraspinatus. It is not an in-phase muscle. It is difficult to harvest. There is risk of radial nerve injury. There is high rate of infection due to its close proximity to the axilla, and the rehab is difficult. Now, if we look at this, this is the photo from Mayo Clinic. Dr. Basim Hassan's article, the lower trap is in line with the infraspinatus, whereas the LD comes from down and goes up. So this is how we do it. We put the patient in lateral position. We mark out the lower trap. We give an so you can see this old scar present already because her arthroscopy got infected. So we give an incision on the spine of the scapula, elevate the lower trapezius, and then if I can show you in the video, it is a very strong muscle. You can lift the whole patient on it. And we elevate the lower trapezius along with the thick periosteum of the child. So an interposition graft is not needed like in adults. So this is the transfer. Now I'll show you another case in which we recorded everything. So this is a patient which had an internal rotation contracture that was not released already. So as you can see, there is no external rotation. You're not able to passively externally rotate. And when we are harvesting it, we are taking the thick periosteum with the lower trapezius so that we don't need an interposition graft. And after whip stitching, you can see that it can easily reach to the infraspinatus tendon, and it's a very strong muscle. Now, in order to release the subscapularis, we put the patient's arm in the chicken wing position through the same incision. This way, the medial border of the scapula gets elevated. And then just give a small, with the help of the cautery, expose the medial border a little bit. And then we subperiostally elevate the subscapularis. Usually the inferior angle of the scapula and the superomedial border are the areas which are missed. And then after that, we passively externally rotate in this position for 5 minutes. We keep it there. And then after 5 minutes, you can see that the passive external rotation is possible. In this, you can see the transfer is done. And then the patient is immobilized in this kind of splint. These splints are available in our country. And you can see the patient is easy, and the scar is only on the posterior side. So cosmetically for the girls, it's very acceptable. And I would like to show you this video. This is the video at exactly the 6 weeks when I removed the splint. The patient can bring his arm to his mouth there and then without any physiotherapy. So this is the patient after 2 months. You can see she can easily bring her hand to the mouth. Thank you.
Thanks, Shoaib. Great case. Andy, go ahead. Oh, you're muted, Andy.
Sorry. This brings up some of the things that we were talking about before. You know, depending on our different locations, we'll have different ways of understanding the status of the shoulder joint before we operate. So, we know in brachial plexus birth injury and these particularly upper trunk injuries, we get contractures of mostly the internal rotators that lead to an internal rotation deformity and actually glenohumeral deformity, right? We're seeing true shape change of the glenohumeral joint, and then looking at the patient in front of us and trying to understand, what is a problem of weakness, what's a problem of tightness, and what is an actual joint, a bony deformity. So how is that, Shoaib, how do you deal with that in your practice in terms of understanding, what you need to do for the joint?
So we usually try to do this transfer in patients that are relatively young, like up to 7 years, 8 years. And then, I mean, beyond 10 years of age, we look at the joint, of course, we see if it's deformed, then we go for the osteotomy, the derotational osteotomy usually, and not the tendon transfers.
And is that intra-op, or is that like do you do
No,
X-ray,
no,
CT, MRI beforehand?
we do X-rays and CT scan to see, and usually they're deformed because we get a lot of ignored patient at the age of 18. I have a patient, he's 22, he wants me to operate, but I don't want to operate on him. So
That could be a great indication for osteotomy. And Ben, can you go over? Oh, sorry.
So I would like to add, I also do the LD transfer. It's a very good transfer. What we've seen is that the terms that Europeans use, external rotation 1 and external rotation 2. This lower trapezius transfer improves external rotation 1, I mean the external rotation at the side of the body, and the LD transfer is much better for external rotation 2, which is the at 90 degrees of abduction. So, I mean, but for beginners, I feel this is a much easier operation because you're working at the back. You're not working in the axilla. Like in the developing countries, we do not have much upper limb surgeons. So I believe this is easier for them to learn and to do compared to the LD transfer.
So really great point. So the options that we have, like the most popular options for tendon transfer, if you think about the line of pull for the lat and teres, that's much more of a vertical line of pull to give you that external rotation, like up in abduction. But it does require dissecting in the axilla, around the axillary nerve, places where people may not be so comfortable. And it also can be hard to know in more extended injuries whether those muscles are working. Whereas the lower trapezius, has that direct line of pull across the back. It's a more horizontal transfer, so it gets you that horizontal external rotation. And I think, I don't know, for me, it's not easier, but maybe I haven't been doing it as long as the lat and teres, and maybe if you're a spine surgeon, it's easier. But, maybe less risky in terms of, not having to operate in the axilla. Those are great points. Praveen, what is your preferred tendon transfer in brachial plexus?
I think I have done this lower trapezius transfer, and it is quite a good transfer, but I would still not leave the LD because latissimus dorsi in children especially, it is a nice transfer to do because that is the deforming force many times. Then they are doing an abduction, the latissimus dorsi is co-contracting. You want to remove the co-contraction. And though the latissimus dorsi is coming from down, but when you attach it onto the infraspinatus and the upper part of the humerus, it gives that double couple type of force, which further can increase the shoulder abduction. So that's why biomechanically, the latissimus dorsi has a different unique status. But I agree, if the passive external rotation is good, and you are not having anything to do with the latissimus dorsi, then infraspinatus, the lower trapezius transfer could work well, yes. But somehow I observe, maybe I am wrong, but I observe many of the tendon transfers not correct the trumpet sign that well. So only I love osteotomies more than tendon transfer. And wherever little bit doubt is there about the good range of passive external rotation, I would go for a humerus external rotation osteotomy, which corrects the trumpet best. In Indian situations, I think most of the children come for operation just because while eating their hand is going up like this. So parents, one main complaint is the trumpet sign. And many tendon transfers don't effectively correct the trumpet sign. You will get external rotation. We are happy that external rotation has come, but child again goes for trumpet. But whenever external rotation osteotomy is done, the trumpet sign gets corrected well, which may be partly because many children have an abduction contracture which does not get addressed by tendon transfer. In fact, it gets worse. And that is the reason why I actually love osteotomy more than tendon transfers.
So would you like to explain us a little bit how much do you derotate, and do you keep your patients in the overhead splint post-operatively?
So how much to rotate would depend on the deficit what the child has. So we do a passive external, active and passive external rotation when you are checking. How much ever deficit of active external rotation is there, you add 15 degrees to that. So in general, patients have 45 degrees of deficit. That is, they will not be able to come to the neutral position. They would be 40 degrees short of neutral. So you add 15-20 degrees to that. So general correction, what is required is 60 degrees. But we make sure that there is good enough amount of internal rotation possible. If the child is able to go to the back pocket, then easily you can rotate 60 degrees. And once you have done this rotation, the hand immediately straight comes to mouth, and then the trumpet is totally gone. Also, while doing this rotation osteotomy, we do an osteotomy in the proximal humerus always. You also assess the abduction contracture what child has. The easy way to do is ask the patient to lie down on the bed. Once the scapula is pushed onto the bed, hand will automatically go to the level of abduction contracture. And when we are doing osteotomy, we do an varus angulation. This varus angulation kind of addresses that abduction contracture, makes the scapula also look better, and corrects the trumpet sign completely.
And do you do it distal to the, sorry,
The proximal
do you
to
do
the
it
insertion of deltoid.
Okay, great. Thank you. Thank you.
So many, points there. Inde, Fatu, do you want to add one more comment and then we'll move on?
Yes, I want to comment to this presentation. In Senegal, we practice this transfer, muscle transfer, even 10 years, and more muscle transfer than osteotomy for shoulder, for head of, and we think that when we have an active rotation extern, it is more than the passive rotation extern we have. And I think that this presentation is very, very, very good because, you know, low trapezes of when you do this and you have an anterior retraction, you have problem for the approach, surgical approach. And this presentation give us a solution with you have to take for for treating to portrait the anterior retraction and use low trapezius. If you don't do this, you can operate the patient using teres major, and with the same approach, you can liberate, you can release the subscapularis, and or you take the latissimus dorsal to have your tendon transfer, and also to release your retraction, your anterior retraction. And it's my first time to see using upper trapezius and using also liberation release of the anterior retraction, treat the anterior retraction with tendon transfer. It is very congratulations for this presenter, and we are more à l'aise. We do first more the tendon transfer than osteotomy. Even children are 12 years and up. 40 we do it for children, and after they don't have, they had the aesthetic position very, very well, and no scleron sign. So this scleral sign have to be delayed when they do physiotherapy. And I think that it is on physiotherapy that they can delete their it is used. They used to do the scleron, and it is in habitude. They used to do it, and it is they have to do every time scleron. But I think that it is retraction anterior retraction is avoided by release of the scapulary, and we have great result for that, for this operation. Thank you.
Thanks, Ndefatu. Thank you. Yeah, it was a really slick technique you showed there, Shoaib, of releasing subscap. Very nice. Andy, maybe I could invite you to sort of lead the faculty in some final closing comments, and then
we lost you again.
I'd like to end. That's okay. Start. Oh.
So I think for me, maybe I can just ask, I think we lost Don, but just our faculty to make a wrap up point that they learned from this morning. For me, I think these three cases highlighted that there are a lot of options depending on the resources available in your location that have not been shown to be better or worse than each other. And so there are definitely some different options that we explored for nerve surgery, for tendon transfers, for testing before and during surgeries. I had put a comment in the chat about the Oberlin transfer that we didn't get to talk about, but I think in certain locations, it might not be very safe to be doing microsurgery on a baby's neck. And in those cases, if, distal nerve transfers, if you have a child with good distal function, can be another way to both push out the time frame of surgery and also, make that surgery a little bit safer. So I think that was a recurring theme today that was really nice to see. Ben, do you have any final comments?
Yeah, I think one thing that was kind of underlying many of these different presentations, and Praveen had commented on this specifically, is the cultural differences and that we have to live within across the globe. So one thing that Praveen talked about is parental preferences for eating, for example. And so that's something that you could listen to these talks and hear what we do in Boston or what's done in India, that may work particularly well, but for cultural reasons in your home countries may not be as suitable for your patients. And so I think knowing to what Andy was just saying is that there's many different options. And so I think just having one or two things that you become particularly comfortable with is most important. And being able to fit that in with what's available in your country and with the expectations that parents are going to have for what their children can do after these things, because by and large, many of these things accomplish the same thing ultimately. And so just having something that you're comfortable with is most important.
Thank you. Praveen, any last comments?
Yeah, I think that point that you need to see your situation where you fit well and what is possible in your setting, and then we can go for it. I think your point of using Oberlin transfer for a person who is not very comfortable in the neck is a great idea. So, because neck exploration in a child is a work, it is not that easy. So, it will take time. But Oberlin transfer, I think, is much safer. And though in loop you can do most of the nerve surgery, but for Oberlin transfer in a baby, I think microscope having is a good thing. And whenever possible, it is better to do under microscope. If you see better, you will be able to do better. And regarding the tendon transfers at the shoulder, it is such a huge topic with people having different preferences. And I think we can have a 2-hour session just discussing and finally come out with no conclusion. But I think we have to control our inherent liking for one procedure. Most of the orthopedic surgeons, they try to drift towards the osteotomy. So not that every patient requires osteotomy. And also many plastic trained people tend to hate osteotomies, but it is not that bad. So we need to control our emotions and get to give what is best for that given child.
Well, I think one thing that we talked a little bit about to jump off of what Praveen just said is you as the surgeon may be able to do a number of these operations, but for tendon transfers specifically, or being able to splint in these special splints, if you don't have those things available to you in your country, then that may not be the best option. So you could do an operation, you could do a tendon transfer, but if you have a family that lives 24 hours away and has very limited resources where they live, and aren't going to be able to rehabilitate a tendon transfer particularly well, then things like an osteotomy are still very good options for these children. And so I guess that's part of what we were just speaking about is many of these things have to be tailored to the resources that are available in your country, and knowing that some things may not work as well. And the shoulder tendon transfers are a particular example of that.
Thanks, Ben. Sorry, we're just getting towards the end of the time for our session, so I'm going to push all the faculty to just sum up a little bit briefly so that we can give time for Federico to give a brief presentation. I see a hand up from Dr. Hatem Safi. Dr. Hatem, would you like to make a comment? Just if you could keep it brief because we're running out of time.
Thank you very much for that web meeting. I would like to say hello to my colleague, Dr. Fatou Coulibaly, and to felicitate her for the exposure. I would like to say some comments about the treatment of sequela of plexus brachial palsy at the shoulder. First of all, we have to explore the shoulder with an MRI or a scanner if we have a loss of passive external rotation, because studies showed that if we have a loss of passive external rotation under than 10 degrees, the probability of having shoulder deformities are important. And then after doing that, we can decide what kind of surgery we can do. If we haven't any deformities of the shoulder, then we can do tendon transfers. In the other hand, if we have deformities of shoulder or retroversion of the glena, then we have to decide what to do. If we have a subluxation and an important retroversion of the glena, we can have to do an osteotomy of the glena for reduce the head of the shoulder in front of the glena. Just another question: have you is somebody have an idea of the osteotomy of Nat, the surgeon, the teeth surgery of Nat, of Raoul Nat, described by Raoul Nat? I didn't have any experience in that, but I learned about, and I want to question: is there somebody who have an experience in that? And thank you for listening. Let me.
Thanks, Hatem.
Voilà.
So,
Thank you.
Hatem, unfortunately, we don't have too much time to go into that now, but we would be very happy to send out a paper on that topic by email. If we could we unfortunately are at the end of the session now, so we'll have to have final closing thoughts. And I'd just like to invite Shoaib to make his final closing thought before we hand it over to Federico. Shoaib?
Thank you, Praveen. It's always pleasure to see you and to present at this excellent platform. Of course, we learn a lot, like we learned so many things from Dr. Praveen today. He's a senior surgeon, and from other faculty members. And I think this is a great initiative that you've done. The problem in my country is a little different. We have everything. We have sutures, we have glues, we have everything, but we do not have the expertise. So now we are inviting our diaspora, different hand surgeons from Pakistan origin, to visit us and to teach us different things, especially microsurgery is not that common in our country. So we are working on it. So it's an excellent platform for everybody, for juniors, seniors, to take inspiration and to learn and share more and more. Thank you.
Okay, it looks like Kieran, I don't know if Kieran is frozen. Was there another comment
Thanks,
from Federico?
And I think that's a fantastic segue into Federico's talk. Federico, would you like to?
Yeah, sorry. It's just written that host disabled participant screen sharing.
Brief points.
I cannot share the presentation.
It should work now if you want to try again.
Okay, let's see. Yeah, hope you can see it now. Can you see it now?
Yes.
So I'm Federico Sibona, a pediatric orthopedic surgeon working for ASC Cure International. That is, there's a series of pediatric orthopedic hospitals around Africa and in the Philippines, and we our hospital has around 25-year history. We perform around 3,200 pediatric orthopedics and plastic surgeries per year, with 4 operating rooms from Monday to Friday. So this is what we do. Some of us do plastic surgeries. We have a plastic surgeon part-time, and we do all sorts of conditions like bow legs, knock knees, cleft lip repair, but and snake bites, like in this case for this child that was walking on a heel. But then why not brachial plexus palsy? Is the frequency is as much as DDH, and we do DDH surgeries like 3 or 4 times a week. But the reasons is lack of expertise, and few trained surgeons in the country. These surgeries are complex, and then there's no money in that, because people would rather do other kind of surgeries that are less time consuming, with more money reward. And then there's too many burn scars contracture compared to the number of plastic surgeons. And as before we said, we lack expertise, but we also lack sutures. We did recently a latissimus dorsi transfer in the infraspinatus fossa, but our smallest needle with a strong suture is 36 millimeters. So you can imagine how much retraction you can have with such a big needle when you're suturing. So problems are practical problems. And when we were talking about microsurgery, I think most of the surgeries can be done with loops, and in this country, almost 0% of the brachial plexus palsy children are treated. So there's no need of microsurgery, because first there's the need to go step by step. So this week we had 2 plastic surgeons from Vanderbilt that came, and I think the best solution for us was to work plastic surgeons and orthopedic surgeons to do these surgeries. So my work in these surgeries is very little. So we have this 7-year-old child that has active shoulder flexion with 90 degrees and active internal rotation limited with a trumpet sign, and no active external rotation with arm adducted, and passive external rotation to neutral. And then she has MRC 2 to 3 for the bicep. Forearm supination is limited, and she uses truncal compensation to supinate neutral or up to 10 degrees. Wrist extension is around 20 degrees, and flexion 30 degrees. Finger and thumb flexion are good in this patient. And on top of all of this, that's another topic. I know she has a chronic radial head dislocation. So given her age, I decided to go with for latissimus dorsi bipolar transfer and humeral derotational osteotomy using the medial approach that was published by Scott Cousin. But the thing is that I realized these are difficult surgeries, and when I saw the plastic surgeons doing the transfer and the dissection of the section of the pedicle, we realized that sometimes we cannot do surgeries up to a certain level if you don't have the expertise, because that's too much, and so we were glad to have someone to teach this, but that needs long time teaching. So the topic of overlaying that we've been doing in these children with internal rotation contracture has been helping us a lot. So this patient was scheduled before the arrival of these 2 plastic surgeons just for humeral derotational osteotomy, but because they came, we managed to complete the surgery with the bipolar latissimus dorsal transfer as an adjunct for, these are some pictures that we took during the surgery, as an adjunct for elbow flexion. And then the child is recovering well. But just to say that we lack both expertise and material. And I think, well, the experience for CURE, these short-term missions of experts coming in our network are great, because we never had any issue with people coming from other countries to teach us how to do things. And because we work there, then we follow up patients, and we didn't have any post-op complications, and whoever came to CURE was just there to help and give us hands. And the end point is that we just want to help these children that have no other treatment. A surgery like that done in a private facility in Kenya is around $20,000, and nobody can afford that. The mean salary is around, leave alone WHO, is around $100 per month. So nobody can afford these kind of surgeries, and the expertise, this is a fight that we can win, and these are the common problem that you face in the hospital, baboon invading the wards. So just to tell you that I really welcome everyone if you really want to help us, because I think brachial plexus palsy, it's a big problem in every country, and like for us orthopedic surgeons, we take a lot of care of hip dysplasia, but this problem is as much as hip dysplasia, and nobody's taking care of it because there's not enough expertise. So I just did this short presentation to try to see if some of you would be interested in missions, because there's a lot of need. And thank you so much for the great presentations that you did. Thank you.
Thank you, Federico. That was wonderful. So thank you to all of our faculty. I see Don has joined us again from the OR. Thank you to everybody. I think we could easily be talking for a week about all of these topics. Well, I know there's a lot of good content on the website, and I'll say thank you again and turn it over to Samita.
Perfect. Thank you all so much to our faculty and to our presenters, and to, of course, all of our learners who joined us today. Really grateful that you all joined on a Saturday to tune in. If you haven't already, please be sure to fill out the post-session survey. We'll also send this out in an email shortly after. And Dr. Bauer, I'll be following up with you about the MRI protocol that you mentioned. We can send that out to everyone as well. Our next session is next weekend, and we'll be chatting about tendon transfers. And we have a session after that about distal radius. And our final session is about upper limb soft tissue coverage. Those who attend all 4 sessions and complete the pre and post surveys for all of them will receive a certificate of participation. So please be sure to do that. And we're very active on WhatsApp. This is a really great place where surgeons from all over the world chime in with questions and comments and resources. So if you join the global orthopedics community, there are plenty of subgroups within it. Particularly the pediatric one might be of particular interest to the folks here. Really great way to have just an informal, real-time, really dynamic discussion. So please scan the QR codes to join us there. We've just revamped our Sona Global Academy website, as we mentioned a little bit earlier, but all of these resources, including lectures from our faculty members, are all up on this website and also available on our YouTube channel for anybody to access for free. And yeah, thank you all so much for joining us today. Feel free to email us if you have any questions, comments, concerns, and we hope to see you all next week.
Thank you all. What a pleasure.
Thank you, Samita. We'll catch up later. I gotta run. Thank you.
Thanks, Andy. Take care.
Bye.
Thanks so much for doing this. And thank you, Federico, for your last comments. And Ben, thanks.
Thank you too. Thank you.
And Fatou, merci beaucoup.
Merci à vous. C'est gentil. Et bon week-end.
Merci beaucoup. Un plaisir. Praveen, Shoaib, thank you so much.